Dr. Narendra Malhotra, Dr. Pawan Dheer, and we have the great players which are experts in their own field, none other than Dr. Shailesh Puntambekar for the uterine transplant and Dr. Krishna Kumar for surrogacy. And indeed, my young colleagues are going to fight it out on this virtual stadium for the Endoscopy Premier League, none other than Dr. Anshumala Shukla for robotic surgery and Dr. Chaitali. Welcome to this great EPL match. This is the numero uno. This is the match of the season. This is the debate of the season which is going to be there. And I have with me none other than the great umpires. I want to introduce Dr. Narendra Malhotra, sir. He is a professor of Dubrovnik International University, past president of ISPAT, past president of ISAR, SAFOG, member FIGO Guidelines Committee. And we all know he is the king of Agra. Agra has got Taj Mahal. And we have Madam Dr. Jaideep and her whole family with Dr. Narendra Malhotra being there as a host and the umpire today with us. Welcome, sir. And I have got the Prince of Ahmedabad, none other than Dr. Pawan Dheer, the senior consultant and infertility specialist, a man with brains, a man with super brain and computers. He remembers all the dates, the events, and all the chronological historical aspects of most of the people I have seen, and that he posts on Facebook. A talented man, president of SOGOC 2006, president BOGS, patron Baruch Menopause Society 2007, and he is the organizing chairperson of Mid SOGOC Baruch 2018. I always meet him in the conference. He is hungry for knowledge and books. We welcome Dr. Pawan Dheer and Dr. Narendra Malhotra. Welcome, sir. Now I hand over the mic to Dr. Pawan Dheer, sir.
Thank you, Dr. Niranjan, and I invite and welcome all the participants to this endoscopy league, which is probably this is the third show Dr. Niranjan is conducting. First of all, the idea of endoscopy league came to my mind, and this is a picture with a great endoscopy surgeon, Dr. Prakash Trivedi. It is a picture of 2001 and 2. When I told him, sir, why we can't start the League of Endoscopic Surgeons like EPL, then he said, well, your idea is good, but who will give us the credential, accreditation that you can be this level surgeon, you can be this level surgeon, and this level surgeon. So this was just like कि बिल्ली के गले में घंटी कौन बांधेगा? But somehow, Dr. Niranjan, today your dream is true, and you are here with third show of Endoscopy Premier League. I congratulate you, and I also see, you can see this is the Goa conference where the Dr. Harry Rich from America, who did the first LAVH at that time, and he was in Gautam Alabadia's conference, and this picture with me is a past reflection that how we were interested in learning the laparoscopy hysterectomies. Although we were doing good vaginal and abdominal hysterectomy, but this was the burning issue, how we created within all of us, and today all of us are here. A great salute to big man. And today's umpire, myself, Dr. Narendra Malhotra, and third umpire is Niranjan Chauhan, and he will be concluding the debates, and he will be the authority over two of us. Dr. Narendra Malhotra, please. This is the person who was Matt's brain from Sweden, where the surrogacy is banned, and he is the person who did the first uterine transplant, successful transplant he has done so far. He has given birth, live baby birth, to the 9 babies in Sweden, where the surrogacy is banned. And learning so many things from him, our own gem from Galaxy Pune, Dr. Sailesh Puntambekar, also learned many things regarding the transplant. He is a basically oncosurgeon, married to a gynecologist's wife, but he has turned himself to a gynecologist. He is blessed with the two daughters, and this was the day, 19th May. I congratulated Shailesh Puntambekar for the first time that he had created a history. He had done the uterine transplant in a patient who belonged to my place, Bharuch only, and mother was remaining in Solapur. She gave the uterus to this patient, and later on, after 1 year, that is exactly in the October month, which we are prevailing the debates. This was a team of Joy Jana, Dr. Sandesh Kade, and Sailesh Puntambekar, who gave a cesarean baby girl to this patient from Gujarat. And this is how I congratulated him on the Facebook. And these slides are reflecting his caliber. He is the first Indian to do this. The Shailesh Puntambekar, I think Dr. Narendra Malhotra will be the right person to introduce this giant from Pune. Sir.
Dr. Sailesh is a good friend of all of us, and he has been famous for the Pune technique of laparoscopic radical hysterectomy, and he's conducted so many courses and everything, and he's credited with India's first uterine transplant and child being born from uterine transplant. And it's indeed a very, very big honor for all of us to have a person like Shailesh amongst us. Welcome, Dr. Sailesh, for the second match. We will go ahead for the first, and of course we have Dr. Anshumala Shukla Kulkarni for the first debate on robotics versus conventional laparoscopic surgery. So ladies and gentlemen, be ready. It is robotics versus conventional surgery, and the question for your voting after listening to both of them is, you can vote. The question is, what would you prefer as a safe and efficient option? Robotic surgery or conventional laparoscopic surgery for complicated surgeries? We can talk for complicated or for simple. And we have from Bombay both the teams. So we have Bombay team versus Bombay, Dr. Anshumala and Dr. Chaitali Mahajan Trivedi, who has been trained in gynecological endoscopy from France, and she's also a Guinness Book World Record holder for removing the largest uterus of 4.1 kgs, and she has an experience of 10,000 laparoscopic surgeries doing it conventionally. So we are going to hear from her conventionally. The rules, ladies, is that you get 8 minutes for a direct. After 7 minutes, I'm going to warn you, 1 minute left, and we will shut you off completely at 8 minutes. You have to mix a lot of science and you have to mix a lot of fun, and you're allowed to, without abusing anyone, to hit below the belt also. Then you get, of course, 2 minutes as rejoinder, and after the 2 minutes, we will give you the umpire's comments, and then the expert third umpire, Dr. Niranjan Chauhan's comments, and then, of course, we will have the voting. The voting results will be declared after both the debates. For the second debate, we have Sailesh Puntambekar and Krishna Kumar. And Dr. Krishna Kumar, you know, the president of IAG now, is no longer elect. He took over, and he's been the general secretary of ISAR, and he's, of course, an excellent human being. And this is the second time he's playing in the EPL. So we are seeing him, seeing Krishna Kumar's second time in this EPL. And Shailesh, he won the first time. Let me start. Let me give the mic to the third umpire to do the toss and declare the match open. Dr. Niranjan.
What an evening it is. The lights are on. It's a day and night match. The stadium is full. Yes, Chaitali, you can look above. The lights are on. It's all bright. And it's a moment to reckon with. We are going ahead with the EPL episode 3. And I have got such a wonderful umpires. I am calling Dr. Pavandir a prince of Gujarat. but he's a man with some brilliance of movements registered in his mind. And that's why we have all these big umpires who are accrediting us. And I would request now the match to be open. I welcome Dr. Anshumala Kulkarni. See the dedication. She was stuck up in the traffic in Mumbai and she did not break those 3 lights. She was very patient with the green light to start on, and then she has reached her home. And now we have Anshumala Shukla and Dr. Chaitali Trivedi getting ready. Dr. Anshumala Shukla Kulkarni is going to bat first, and Chaitali Trivedi be ready to bowl. And we are going to start. The umpires have given the signal. The crowd is roaring, and there goes the whistle. 4, 3, 2, 1. And that's it. It's all yours. Go ahead, Dr.
Dr. Anshumala, you can share your screen. Your time starts now. It is 18:15 and you get 8 minutes to talk whatever you want to. Please
Perfect.
don't
So,
waste time asking, am I audible?
yes. Yes, am I audible? I'm audible, right?
You are audible. So don't waste that
Yes.
time.
So,
Screen,
yes.
please, full screen.
Screen. I did do the screen thing. Not sure
Yeah.
what happened. Right. Just give me one second. Just let me get this. Right. So, thank you very much, Dr. Niranjan, and this unique concept of having a Premier League where we're going to battle out with our wits rather than our skill in, so to speak.
Madam, please share your screen.
Yes,
We
I
can't
am
see the
doing
screen.
that. I am doing that. Just give me a second. I'm just going to do that. Just give me a second. So, I think we have been very old associates, myself and Dr. Chaitali, and we both know, we've started off our learning at pretty much the same time and place. And I must say that adaptation of to new technology is something both of us would agree upon is something we should always endeavor to do. Just sharing my screen now in a second. Finally. So, we, like I said, we started off our training before, and my worthy opponent, or rather my, one we started our careers with together, has also learned a lot of adaptation of technology, I'm sure. And, what's new that could be adapted, I think in minimal access surgery, we've been there, done that, enough amount of things that have been done. And I think the newest thing that we could possibly do is to bring on artificial intelligence into doing routine surgery. And what better than to use a robot machine to do that? We are debating whether it's robot versus laparoscopy, but frankly, if you ask me, it's just comparing apples with apples. I mean, we both are minimal access surgeries. We are both going to go through minimal access routes. We are going to do pretty much the same surgeries, the same technique does not change. However, there is a big change between what is robotic versus laparoscopic surgery. As we say, change is something that always is met with resistance. It always is met with resistance. We are always in a comfort zone and do not want to push our boundaries at any point of time. So when Eugene Pauly invented the first TV remote, it was called as lazy bones. And like, who would ever want to do that? Why can't you just walk up to your television screen and do the walk? However, we all know now that remote control is something we cannot even part with, and it is something that often battles are fought with at home right now. So change is the only constant. We have to learn to adapt. We are all agreeable that we can go through a transition phase where we don't know whether this is correct or that is correct. However, with time, we know that that is where we have to be. We all know minimal access surgery should be done. That has become a standard of care for pretty much most of our benign gynecological work. And, what better way to do minimal access surgery if it was not by using everything else we knew in open surgery. So when you're taught in the old school where you know open surgery, you're using your eyes with three-dimensional view, you're using your hands with wristed instruments. Now, if I'm able to bring your minimal access work along with all of these other advantages, then I'm pretty much, tying the knot between laparoscopy and laparotomy and giving you the benefits of both. Three-dimensional vision, of course, that's a game changer in this entire robotic platform. However, this surgery, this particular vision is not like you would have said screen, things coming flying out of the screen, or a three-dimensional screen that you would see with wearing binocular glasses. This is going to be an immersive view. This is going to be a depth perception. It's an immersive view. There was a famous person who said that 3D HD technology is amazing with good precision, accuracy, and depth perception is incredible. It now seems like laparoscopic surgeons are actually operating with one eye closed, and 3D has enhanced the skill of talented surgeons. So we all know 3D technology is really, the correct thing to do. So now, what about the other step? The other step in this particular. So if we were to look at this chopstick, which is doing our surgery, you have, so you've improved your vision in surgery in laparoscopy by using three-dimensional view, but you're still using chopsticks. You're still using a chopstick to do the surgery as you would do. What if I brought in something which was able to move its hand and do the same thing that you were struggling to do with the help of chopsticks? Of course, that's where the Da Vinci move makes a big difference. So my take on the same dialogue of saying 3D was like laparoscopy, doing surgery with one eye closed. I think the robot is amazing because it gives you the three-dimensional view. Along with it, it gives you 7 degrees of freedom. Your hands are now rotating at 380 degrees of rotation as compared to the chopstick that you were using before. And so therefore, my comment would be that up till now, laparoscopic surgeons seemed like we were operating with only one left eye and 2 left hands. So now you have 3 hands, not just one, not 2, 3 hands with which you can do the same surgery. Obviously, you're going to be able to do far better and far more complicated surgeries as compared to routine laparoscopy that is there. So robot is basically allowing talented surgeons who are doing good laparoscopic surgery to push their limits and perform even more complex surgeries. We often know that we are dependent on our assistants in laparoscopic surgery who are generally tired, overworked, or simply bored, not interested. Unless you are one of those who have the privilege of having fellows who are interested. But then most of us are working in teaching institutes or corporates where our assistant may not necessarily be someone who's interested. And dealing with an assistant like this who's tired, overworked, or bored can be a task. However, with the Da Vinci, it's ever ready. There is no tantrum. There is no question of show of interest. You just plug it, dock it, and forget about it. It can do everything for you in the sense it follows every single action that you have to do. The role of the assistant has become very, very minimum. So it's really not important whether they're able to show the camera to you well. You can adjust your camera very well. It doesn't matter if it's able to move this instrument there. You have 3 hands now. You don't need the assistant to hold a particular thing in a particular way. You shift your arms and you're able to go from arm 2 to arm 3 and just work like as if you had an assistant all over, and you're not bending over anybody. So ergonomics is very, very important in robotics, and you must understand that here you're not bending over in different difficult positions to be able to do a surgery. Here you are actually very comfortable. You are going to be seated ergonomically, and you're going to be able to do surgery very comfortably seated. So robotic surgery really is laparoscopy on skates. We were called as the country of snake charmers. We have moved to being people who are providing a lot of call center solution kind of things, which is basically country of mouse users. Now we are known all over for our technology that we afford to the world. And I think it's time for us to adapt and not yet be called a country where only doing laparoscopic surgery, but getting on to doing what is the newest on the kid on the block. What are the advantages? Like I said, it's a 3-dimensional 10-time magnified view, which is immersive. There's very big difference between using a screen, which is called a 3-dimensional HD view, wherein you still have a distance from the screen, as compared to an immersive view where you feel that you're a part of the patient. It is not something which is viewed from a distance where something is coming at you artificially. Here you are immersive, which means your head is in the console and you feel that you are a part of the patient. You're actually looking in like you would look in with a laparoscopic surgery. You have 7 degrees of freedom, motion scaling. So, even if you grow older and your hands have tremors, you can still go ahead and do surgery. There is no limits on that. And it has a shorter learning curve. I think that is what I'm going to talk about next, wherein other than having your 3-dimensional view, your precise instrumentation, motion scaling, you also have a shorter learning curve. So at first, they will ask you why you're doing it, and later they'll ask you how you did it. I think it's time for everyone to change to that. As you can see, the rate of abdominal surgeries across the US has actually declined once the Da Vinci came forwards, because that was taken over by the robot assisted surgery. However, vaginal surgery still do have their stable position all through, and so do laparoscopy. However, there were more and more people who were able to now do minimal access surgery. We all know that laparoscopy has a very long learning curve, and often people would give up and still continue to do abdominal surgeries. But with the onset of robot making it easier for a surgeon to adapt to this technology with a shorter learning curve, we are seeing a big rise in the number of minimal access work being done for a patient. So in totality, you can see here that the number of patients who are now getting minimal access work is double as compared to what we were doing when we were having only laparoscopy. We have additions. We have additions in laparoscopy like the ICG, which can be used. We have so many people doing laparoscopy, robotic surgery now across India, even in AIMS. We have almost 40 to 50,000 surgeries being done in India. We have newer systems available. Training is something which is very, very important in robot. You can do it because you can be a proctor, you can have a teaching console to help train the patient, the person. Cost, if you look at robotic surgery versus laparoscopic surgery, yes, we have a very costly instrument. But if you look at the energy devices and all of the other paraphernalia in laparoscopic and you total that amount, I think it balances it out. I mean, if you're going to be safe with the patient, not going to reuse things which are for single use only, then you are going to actually add almost the same amount of money as you would with robot. And look, here you're doing a safe surgery which is in the correct protocol without having to compromise on any kind of sterility that you would see otherwise in laparoscopic surgery. So our goals as a surgeon should be to have a safe surgery, to have a reproducible surgery, which is in
time up, ma'am. You can summarize this in your rejoinder. Time up. I'm sorry, can't give you in your 2 minutes.
I was anyways on my last. Yeah, I was on my last slide. Thank you so much. Thank you.
This. So yes, that was a good start, a good batting, good batting on the new technology, on how the new technology. And she's insisting it's going to be cricket with a single person, no teams. It's a one-man cricket team. So that's what Anshumala, I could gather, one-man team. And let's see, Chaitali, you need assistance, you need so many people, you need so many holes, and she's just doing it one-man, single-handed. So what do you say about it? Your time starts now, 18:26. You can share your slide, please.
Sir, I would like to comment that resentment is an early warning sign for needed change. And I welcome Dr. Chaitali to debate for the conventional laparoscopy surgery. I think she is going to be ready soon.
Chaitali, you have to open the slide first and then share. I think you've not done open the slide in your background. In the meantime, we can have comments from Pavandhir because there is some technical glitch, and we can give her 1 minute extra to solve that. After that, her time will start ticking off. So Pavan has commented, yes, Dr. Niranjan. After unmuting yourself, please. Unmute yourself, please.
Are my slides not visible now?
No,
madam, you have to open.
Close this down, open the screen, open the slides on your screen, then share it.
We are having strategic timeout. Strategic timeout. The bowling was superb by Dr. Chaitali, and it was a sixer beyond the stadium ground by Anshumala Shukla. Anshumala Shukla, you have done a wonderful job. The score is beyond. I hope Chaitali can match your score. And we have got comments here running. I want to read few comments before Dr. Chaitali starts.
Is this visible now?
No, madam. Support, can you please help, Dr. Chaitali?
Yes, open your presentation.
I've opened the presentation.
No, you're trying to open now.
Can please open.
You're trying to open now. Open the presentation like a PPT, minimize it, and then.
It's open on the desktop.
Now. It will not open like this. It will not open like this. You have to open it first as a PPT.
I've opened that.
No, it's
You
not
open it, you minimize it again, you minimize it again. You minimize it, then stop sharing, start sharing again.
Okay.
Yeah. You now start
Oh.
sharing again. Now you share the screen.
Yeah, so we have comments from Dr. Kaveri Shaw, Jabalpur, wonderful talk. Dr. Kaveri, thank you for joining. You were with me about 10 years back in the basic infertility
Arey, you have-
and
Chaitanya ji,
endoscopy management course.
you have to
Yeah.
open the PowerPoint. Your PowerPoint is not opened.
You
Open it
cannot open
fully.
the PowerPoint and share. Open the PowerPoint first as you are presenting. Open it on your screen, and then minimize it.
Please open in the background. Then click on
Ronak,
the
please
search.
guide and open and give it to madam.
So we will be
Yes.
having
What are the other comments?
Yes, sir. Dr. Mitra Saxena from Rewari, going to enjoy this for sure. Dr. Mahabuba Khatun, Rangpur, very good. And there are many more comments which are coming. We'll be having a strategic timeout. The support is going to be there, and Anshumala has hit a 6 beyond the boundaries, and we are waiting for Dr. Chaitali to come on the batting pitch. Sir, Dr. Narendra Malhotra, would you like to add something about the pitch? Would you like to talk about something about the weather?
So the weather is beautiful in
Tell me.
Bombay, in Agra. What we are seeing is that robotic surgery versus conventional laparoscopic surgery. Now the points which have been put forward, fantastic, and I would love to do robotic surgery if I could buy a robot. So, but I can buy only a cricket bat and a ball. So, and 3 wickets. So the 3 wickets are my hands and this thing. So that makes me do whatever the robot can do. I'm not debating. If Chaitali doesn't, then I'll start my debate. No, ऐसे नहीं खोलेगा Chaitali. पहले presentation को open करो. इसमें नहीं खोलेगा presentation. पहले.
So I would like to add here, while we have one hand catches and the young have been dynamic with their fitness on the field, there is a lot of brilliance and newness which I see. This is the new learning for all of us. That's the brilliance. We have seen the young.
Best thing I liked about Anshumala was that she's fielding single-handed in the offside and leg side both. So leg slip and off slip, first slip, both the same person. That's what the robot can do. And she's batting and then going back and bowling and hitting the 6 again. Fantastic. So she's trying to open the presentation in the share screen. The presentation has to be opened first, and then the share screen has to be started.
I think the robots have even hacked Chaitali Mahajan's screen.
Oh my God,
This
Niranjan.
is something like sabotage, like what it had happened yesterday when there was a major power outbreak in Mumbai. And I think Anshumala Kulkarni is smiling from one end to another. And she is very happy that Dr.
Chaitali, open your presentation. Open your presentation, जैसे कि open करते हो, then share the screen. First presentation को खोल लो, PPT दिखेगा first slide, and then start sharing the screen.
Sir, Dr. Niranjan says that he wants to carry laparoscopy to every gynecologist armamentarium. And he wants to make all the gynecologists and make laparoscopic surgeons to make Atmanirbhar Bharat.
Yes, that is the need of the hour. Since our Prime Minister has said that we have to be Atmanirbhar. And there we
That's
come.
it.
Yes.
So your time starts now. It is 6:32. You get 8 minutes. At 7 minutes, I'm going to give you a warning. Chaitali Mahajan Trivedi on conventional laparoscopy versus robotic.
Hello, good evening, everyone, and thank you for giving me this opportunity to speak in the Premier League and not wasting any further time. We started off with open surgery where we had these large ugly scars, and then that was when we passed out, and then after that we had to learn this new technique, laparoscopy. Laparoscopy at that time was 2-dimensional laparoscopy, and there was training required, and we evolved through that. We went into 3D laparoscopy and then into robotics also. Earlier, laparoscopy was not accepted globally, basically because it needed training, it needed equipment and support, and also the hand-eye coordination was something which was new and which needed to be learned as against the open surgery, and you had to develop more cognitive and psychomotor skills uh, for doing laparoscopic surgery. Now, what were the problems which we were facing? That was the visualization, especially with the 0-degree scope. There was limited vision, then there was lack of depth perception, and we had fixed range of laparoscopy ports, hand-eye coordination, as I already mentioned. So 2D laparoscopy was something like you close one eye, like a monocular vision, and then you operate. That was making things extremely difficult. And then we came into something which is called as 3D laparoscopy. 3D laparoscopy gave a complete new dimension to laparoscopy because now we could see with both our eyes. As even Anshu rightly mentioned, that it is like viewing with both your eyes. You get a complete depth perception while laparoscopy through 3D laparoscopes because there are two scopes inside. So depth perception, so suturing skills became better, hand-eye coordination became very easy. The learning curve dropped drastically after the 3D laparoscopy came into picture. And then there was a third new dimension which came up, which was robotics. Now, robotics also has 3D and it has articulating instruments, making things much easier. But is it really easier? I mean, comparing the outcomes to conventional laparoscopy, it used to take a lot of time and there is more cost. I mean, docking itself takes around half an hour. Imagine we have an ectopic pregnancy, we immediately wheel the patient inside the OT, we have to get the OT ready, and then wait, there's half an hour docking which is required before we start the 3D laparoscopy. I mean, the 3D robotic surgery. I mean, that is, if you consider that you're going to do robotics in all the regular gynecological surgeries, I don't think that is quite possible because there are emergencies and also the routine time taking the operation time is quite limited or the OT time is quite limited. And if you have to finish cases in that point of time, you cannot be doing robotic surgery for each and every case. I mean, docking, undocking is time consuming and is tiring also. Although the surgery per se is not tiring only for the surgeon because the surgeon is sitting on the console, but his assistants are still standing there next to the patient. And again, they also need to have training to do the laparoscopy because they have to do some sharing as in suction. They have to do a lot of activities while they are along with the patient also. So it's not only the surgeon who's operating. The surgeon gets a wonderful three-dimensional view. He can manipulate the articulating instruments and all, but he does need the help of his assistants there. Also, I mean, I would compare a robotic surgery to something like if you have a patient and you want to measure his blood pressure and you have to take him to the ICU to measure the blood pressure. I mean, it's that high tech. I mean, do you really need that? Yes, I would surely agree that robotic has secured its place in radical surgeries, as in a radical CA cervix or a radical endometrial surgery, early stage carcinoma ovary. It has taken its place. But then what about the routine regular gynecological surgeries? I mean, CA cases do not consider are not the major chunk of gynecological surgeries. The major chunk is hysterectomies, myomectomies, diagnostics, tubal ligations, recanalizations, and so on. And what about hysteroscopy? Can you do hysteroscopy also by robotics? I doubt that. Okay, and when you consider anesthesia, also they have the anesthetists are not very happy with this deep Renelenberg condition because the surgical time is quite high. Then you also have facial edema and ocular injuries happening because of the position per se. Now, if we are comparing the scars, look at the amount and the size of the scars that Da Vinci surgery is making. I mean, there are big 10 millimeter scars on the abdomen, more than a 5 millimeter scars which we have in laparoscopy. And when a patient survey was done, they also mentioned that they did not like the scars which were made in the robotic surgeries because they were quite obviously seen. So although robotic surgery has the best of articulating instruments which make surgery easy, but suturing is not the only thing. There is a lot which which needs to be done while we do a robotic surgery, and I feel that since now 3D vision has come in the picture, it has drastically reduced the learning curve. The recurring costs are very less in this. The 3D vision, and the whole team can actually enjoy the 3D vision. It's not only the surgeon, and also there is
1 minute left.
Yeah. So I'm actually very open to new procedures, but robotics still has time to be universally accepted as a conventional procedure. Of course, money does come into the picture. It is very costly for the patient's pocket. It's very costly for the institute to set up a robo there. And I don't think it is possible for the small nursing homes to for all of them to have a robo in their hospitals. The space required in the OT is also quite much. And then, of course, insurance companies also do not really cover the cost for the high cost for the surgery. So, considering all these factors,
Time up. You'll get it in your rejoinder to show these two papers. So time up. Fantastic batting and bowling by Chaitali. Fantastic points brought up. And what I could make out is that she is open to new procedures, but she will trust her brain more than the artificial intelligence this big, huge metallic thing has. Yes, Dr. Pavandeep, your expert comment before they go for a rejoinder. One comment only. So please stop sharing your screen, and Anshumala can be ready for the rejoinder. Pavan, you want to say something? Unmute.
Please unmute.
Pavan, unmute.
Sir, I would say that for conventional gynecological surgeries, the traditional laparoscopy is best. And if you have got money out of that, you can buy a 3D laparoscope.
Don't judge them right now. Let them talk the rejoinder.
Okay.
Umpires, calm down. Umpires, ground umpires. We have to be very focused. And the bowling and batting has occurred. While I see the lights drawing on one side, I can see the witness by Narendra Malhotra, our senior umpire, and Dr. Pavandeep. I can vouch for the fact that the sunlight coming down will help open the next aspect of rebuttals from either side. I got few comments here. Dr. Archana Baser from Indore. After robotic, couple of my patients had total occlusion of vagina in simple menorrhagia case. Do we have explanation? Oh my God. I can't believe this. What is happening? Dr. Anurita Singh from Meerut. Anshumala, great to see you again. Wonderful the way you have presented. Dr. Ram Kumar from Vizag. Nice talk. Different approach by organizers. Congratulations to Science Integra, TOG. Dr. Mitra Saxena, most awaited webinar. Good, interesting start. And there are 4 new messages. Conventional surgery, robotic surgery. We are going to find out now. We are going to wait for the rebuttals. Dr. Maninder Ahuja, Faridabad, wonderful, batting first round. Dr. Mitra Saxena Rewari, माहौल मजेदार और ये पल्ले के बाहरी किनारे को लगकर गेंद विरोचा कोटला मैदान के बाहर जा चुकी है.
So the catch missed. Anshumala, yes, 2 minutes to you. Everyone,
All
please
right.
be ready to vote after the rebuttal. Anshumala, yours, 2 minutes.
Yes,
18,
starting now.
23, 40,
So,
yeah.
so as my esteemed colleague Chaitali did mention that yes, technology has to be accepted. Robot, of course, is slightly newer as compared to most of the other technologies that we've used. And I would like to put the debate of using a robot, whether it is good or not good, into two main aspects. One is whether it's actually scientifically proven, and the other becomes whether it is actually feasible to do it as a cost perspective. Now, if you look at scientific data, look, you accept three-dimensional view is good. Try the immersive view of 3 dimensions. It's even better. Whether you need assistants who can have some limited laparoscopy skills, yes, you have to teach your assistant something in laparoscopy for sure, but we are not dependent on them. We have robots now which are actually having suction irrigation integrated into them. They have even got the smarter energy devices integrated into the robots, so that concept of saying the assistant still needs to be hanging around and doing something is becoming less and less important. Third thing about anesthesia concerns, we have to have a team. Docking does not take half an hour. That's probably an old concept that used to happen with the first generation robots, which is the S generation, which took almost 20 minutes. But now it takes us exactly 5 minutes to dock the robot. We don't use the robot for anything which is a simple surgery, which could be done easily by somebody who's actually supposed to be a trainee. So, a level 1 or a level 2 surgery, which is just up to a salpingectomy, ovarian cystectomy. I think you should reserve the robot's expertise for something far more complicated in benign gynecology, though of course malignancy has its own benefits. But in benign gynecology, if you're looking at a grade 4 endometriosis, tell me, other than having metastasis, is endometriosis any different from oncology cancer? It grows and destroys every organ that is surrounding it. And if you're going to be dealing with a grade 4 endometriosis, with rectal adhesions, with bladder, I think the robot, it gives you an opportunity to do a fantastic surgery in a least minimum time, because you see better. You don't have any bleeding. You are looking at every single minute arteriole very well. About anesthesia concerns, the anesthetists have adapted to it. There are enough number of papers where they have proven safety of periorbital edema, whether it is steep Trendelenburg. These are all challenges which can be there. So it's basically a challenge which is overcome by the anesthetist as well. So if your team of anesthetists is good, I'm sure robot can be done. About scars, we have the XI. The XI has 8 ports. All ports are the same.
Fantastically brought out the rebuttal. Time is up. We cannot let you speak anymore.
Okay.
Thank you very much. Thank you very much. The 2 minutes of rejoinder by Chaitali start now. Chaitali, you're all yours.
Well, now that Anshu has actually accepted that it is robotic is evolving, but it is evolving. It is not evolved. There is no accepted norm. There are the robots keep changing every now and then. Looking at the costs involved, I mean, it is not at all feasible for any regular gynecologist or a laparoscopic surgeon, also for that matter, to keep on changing robots and buying robots. And as I said, set up in a clinic or a hospital, a smaller hospital, is not at all possible. It's only for the higher institutes that they can have robots. What about the costs? The costs involved are way too high. They are skyrocketing. Looking at per surgery cost is also high. I mean, okay, if there was only one-time cost, I can understand. What about per surgical cost? Each equipment, the hand costs so much. I mean, there is no backup, no support. Insurance companies don't want to pay that much. Patient has to bear. Look at this COVID situation. People have no money in their pockets, and now are they going to pay that huge amount of money for just a routine surgery, which can be done laparoscopically and equally well, but in by good trained hands, and a surgery which is well accepted?
Okay, time up. Time up. Points well brought out. Ladies and gentlemen, audience, your vote question is: what do you prefer as safe and efficient option? Robotic surgery or conventional laparoscopic surgery? Pavandeer, your comments first. Unmute yourself. Unmute, please. Unmute.
Dr. Pavan, please.
Yes.
Yeah.
Sir,
Yeah.
it is audible?
Yes.
Sir, I would like to say that robot is more or less marketing hype from the reality. It's very costly for Indian scenario. It costs nearly 8 to 10 crores to 15 crores.
Biased umpiring.
Yes. Sir, the same will be your side. You don't have the robot in your hospital. This umpire doesn't belong to Pakistan.
Okay, guys. Okay, third umpire, Dr. Narendra Malhotra, with your permission.
Yes, all yours.
Wonderful,
Yes,
wonderful rebuttal by Dr. Anshumala Kulkarni. Yes, it doesn't take half an hour, Chaitali. It doesn't take half an hour, okay? So please remember that. Do not try to misguide people here. And Dr. Anshumala Kulkarni, you have done a wonderful job. I appreciate the way you have handled the situation. And Chaitali, apart from that strategic timeout, which we have gone through, you have also batted excellently. I have comments for you, Dr. Chaitali and Dr. Anshumala Shukla. Dr. Akhi Chikalkar from Kalyan. Nice to listen to you, Chaitali, after a long time. Dr. Jyoti Malik, Bahadurgarh. Looks like match is already fixed. No joke. No, Dr. Jyoti Malik, it cannot be fixed. No, we are having a poll and the poll is online. It has been sent to all the registered users and it is going to be announced after the end of the second power play 2. Dr. Kanchan Prasad, Muradabad, lovely and interesting match. Dr. Sushma Bakshi, Vadodara, great match with excellent umpiring. Dr. Kavita Naragoni, Hyderabad, I have experience with robotic surgery. Technological advantage of the robot should be accepted without any inhibitions except for the cost. Why should we say no to the advancing technology? Yes, Anshumala Kulkarni, there are audience who are roaring, who are very happy with the way you have answered. Dr. Shobha Gudi, Bengaluru, cost is an important consideration. Dr. Shobha Gudi again, hospitals must use the same funds to promote preventive care like cancer screening and family planning. And that goes to Dr. Chaitali Trivedi. Dr. Charmila, excellent topic. Well, this will go on and on. But we have the next excellent debate and I hand over the mic to Dr. Narendra Malhotra, sir.
So we saw the comments on both sides. Now, I would love using a robot because I use the robots to clean my carpets also.
Yes.
So when they can do all household stuff, why can't they do all the complicated surgeries with the artificial intelligence?
Perfect.
So okay, we move on to the match number 2. We can mute ourselves. The match number 2 is very, very interesting and very, very exciting. It's women who cannot have their own babies in their own uterus. So absent uterus or surgically removed uterus. Uterine transplant versus surrogacy. Whatever you're going to do, it's the third person uterus. So let's see. And we have none other than Dr. Shailesh to start off with uterine transplant.
So good evening, everybody. And at the outset, let me thank Dr. Niranjan and Dr. Narendra Malhotra and Dr. Dheer for giving me this opportunity. So I think this is the league I'm fighting with my good friend Dr. Krishna Kumar. The only question that I would ask him is, what do you do if there is no uterus? And that is a question that I would like to ask him repeatedly. What is the exact idea? 1 out of 5,000 females have MRKH, and that is the most important thing. We get about, so we have possibly looking at 1,29,000 MRKH patient. What is the success rate in the best centers? I'm not asking you what is projected, but what is in the literature is 30%. IVF will only address only ovarian and tubal factors. Cause remaining unsuccessful in 70%. Maybe uterine factors. Do you have an answer to this? There is no answer. 50 years after the IVF, 1978, the first lady was born in Cambridge, Leslie Brown. And after that, we still had no answer for absolute uterine factor infertility. And these are the various factors where you have no answers. Even today in IVF, when you have an hysterectomy, cervical cancer or MRKH syndrome, non-functional uterus. Why not adoption? We all know the legal issues and documentation, the psychological issues faced by the children. And of course, surrogacy, I think I'm not an expert onto this, but the very fact that the government of India has taken this issue in their own hand indicates that surrogacy's laws were actually altruistic. Altruistic meaning there was to be interpreted by everybody in their own particular way. A lot of Muslim countries do not allow surrogacy. A lot of European countries do not allow surrogacy because there are ethical issues involved with this. So what we are looking at is a technology which is moving forward like uterine transplant versus a technology which is still like the Wright brothers going on with the IVF, no difference in the total management except for little amount of percentages from 35% to 50%, 40%, but not everybody can be made happy. Uterine transplant is a complete answer to motherhood because adoption will give you legal motherhood, surrogacy will give you genetic motherhood, but what an uterine transplant will do will give you legal plus genetic plus gestational motherhood, a wholesome experience. Every woman who is born in the country and in the world wants to have menses at a certain age and wants to become mother at some point of time. So in 1977, the first time when Lucy Brown was born on 25th July 1978 in Manchester, and then second was when our own Dr. Subhash Mukherjee became the first physician in 1978 and the second in the world to create a test tube baby. What is the world transplant scenario? The first ever transplant took place in 2000, but the first live birth took place in 2014. It just took 14 years to develop this. Majority of the uterus had to be removed because of rejection, because they were cadaveric transplants which were done. Now we have more than 20 live births which have been reported. And these are the various countries. We proudly stand as one of the countries who gave the 12th baby in the world. And we did this technology completely laparoscopy. In Turkey, when the first transplant was done, there was a donor problem. And in 2014, Mads Brainstorm did the first open surgery. What in our country we did that he is still taking 14 hours, and that was the biggest objection which came in. We did it laparoscopically, and now we are even planning to do it robotically. So the big question that people ask, the lady has to undergo 3 surgeries, one to put on the transplant, then the cesarean, and then to take out the entire uterus. This will change because we will be putting the uterus also laparoscopically. So December 2017, the first baby to be born out of a deceased donor in Brazil, and of course in China also, and Radha is the first one in Asia Pacific. And we made this possible through a technological advancement which we did, and we did this totally with laparoscopic removal. So the uterus donor, the objection that it is there, that the donor also suffers, we did it laparoscopically, and not only we did it laparoscopically, we also published it laparoscopically. The second thing that we did was, instead of using the uterine vein, we have used the ovarian vein, which becomes very, very easy, and a surgical technique using the utero-ovarian anastomosis rather than having the uterine vein and the internal iliac vein has made it possible. So according to the current progress, uterine transplantation is going at a rapid speed. What is more important is that there are 3 things which are involved in the fertility: the tubes, the ovaries, and the uterus. We only addressed 2, and we were very happy for 50 years. Now IVF has no answer except surrogacy, but then uterine transplant is a very, very safe option. There has not been any death. Thank you very much. So uterine transplant, I think, is not the future, but it will become the gold standard once the kind of surgeries that we do become much more easier. The uterus which is transplanted is a uterus which is known for its fertility. So you're not dealing with somebody who's not known with fertility. And therefore, this may also become an answer to people who are having uterine factor as a cause of infertility. So I think these are my few slides where I feel that this is the future. And I think I'll wait for Dr. Krishna Kumar. Thank you very much, Dr. Malhotra, for giving me time.
Thank you very much for bringing out very, very important points. It's your baby, legally, anatomically, genetically, whatever, physiologically, everything. It's in your thing. Krishna Kumar, I don't know how you're going to bat this out. It's yours completely, 100%. So we will go to the comments later. We'll start with Krishna Kumar because this is a very, very interesting situation. It is landing up towards a super over, I think, hopefully, and we'll see that. Krishna Kumar, all yours. Your 8 minutes starts now. It is 6:58. Unmute, please.
Yeah, can hear.
Yeah.
Yeah. See, this particular match, even before the ball is bowled, the wickets are down for the uterus transplant, I believe. No doubt that my friend, Dr. Puntambekar, is the Tendulkar of endoscopic surgery. He is the god of endoscopic surgery, absolutely no doubt, an excellent presentation. But if he chooses, what would have happened if Tendulkar was relegated only to the gully cricket? Surrogacy, we know what it is. It is by practice by a woman gives birth to a baby in order to give it to someone who cannot have children. A woman with absolute uterine factor infertility, it definitely, this is a good option. Surrogacy gives you both social and genetic sense. Surrogacy is not new to India. It was known in Hindu mythology also, and there is no conflict between Hinduism and ART. In Hindu mythology, there is a lot of story, even in the Puranas, Bhagavatas, which suggests that practice of surrogacy was existed even in those days. And the most famous is the birth of the 100 Kauravas and one Dushala from the 101 cells, which were incubated in an environment where nutrient medium was formed. So it definitely goes to prove that surrogacy is not new to India, but modern art era, it is well established, accepted procedure, came in for scrutiny for few reasons, mainly not being regulated. And we know that, mine is jumping. Now the main was, it was a much needed source of revenue for women facing poverty in developing countries, but it was blamed that it is an exploitation of women in developing countries for the reproductive needs of the affluent men. But, there is something wrong with my computer. I'm sorry. So there are now education going on, and definitely surrogacy has to be considered as a labor, and it's a legitimate form of work which requires same wage and safety standard as other forms of labor, and payment of surrogacy need to be high enough to avoid exploitation by underpayment. So studies have shown that there is no effect on children born through surrogacy, and all families who have gone through surrogacy are completely happy as far as the child development is concerned, and also the parenting, that is the family and the child bonding, which has been proven beyond doubt at the age of 1, 2, 7, have all shown greater psychology, well-being and adaptation, and at no stage they have proven that there is any difference, and there are no differences in maternal positive, negative attitudes and child adjustment. The researchers concluded that surrogacy families continue to function well. The capital of surrogacy in world, Dr. Anand, Dr. Nainas Patel, this beautiful article definitely gone beyond to prove that surrogacy has proved to be a blessing and medical marvel for many couples to date. And all positives and negatives taken into consideration, we cannot negate the fact that gestational surrogacy gives hopes to individuals and couples who could not otherwise build a family outside of adoption. And now with the surrogacy law almost coming in place, where it prohibits only NRI and foreign surrogacy, but if it was left unregulated, lead to much profit accruing to middlemen, commercial agencies rather than surrogate mothers, all those things will be now under definitely not there. So with a referee, state now watching, and also a facility for DRS, where is the question of cheating? So commercial surrogacy should be here to stay, and if properly regulated, it definitely involves a contract which stipulates all the rights and responsibilities of both the parties, making it clear that surrogate cannot harm the fetus and that she deserves adequate compensation for her labor. And definitely it's a way of creating opportunity for intended parents to fulfill their wish for a child and also empower the surrogate woman concerned. Uterus transplant, we know it's a temporary procedure. It involves a surgery for the donor and 3 surgery for the recipient. A transplant, seizure, and ultimately removal after 1 or 2 child. It is not a permanent procedure, and any type of transplant requires the patient to take a lot of immunosuppressant drugs, apart from all the complications, which is blood loss, infection, organ rejection, and potential for anti-rejection medication. And definitely it has its own emotional, financial burdens. Couple have to go further fertility treatment like ovum pickup and freezing. And the disadvantage is definitely the uterine blood flow. If it is reduced, it can cause growth retardation to the developing fetus. It can cause preeclampsia, eclampsia, and hypertensive disorders. And the potential fetal teratogenic effects of exposure to immunosuppressants is still not unproven. It can still lead to a lot of, and this article by ASR and the American Society of Reproductive Medicine, that uterine transplant is not a single man's job. It requires a great team effort. A lot of members are required. And it also concludes that uterus transplant is an experimental procedure right now for the treatment of absolute uterus factor infertility and requires excellent animal model training and cadaver lab training before prior attempting transplantation in human subjects. So it has no match as far as safety of surrogacy is concerned. And then we must ask ourselves, what is more important, the experience of pregnancy or the health of the baby and child? So
1 minute left. 1 minute left. I think he's got disconnected. Dr. Krishna Kumar has got disconnected because of internet problems. So that is what his views were on especially mythology, going back to Mahabharata, and then of course going to a lot of complications, Dr. Putambakar. So you are doing something which is causing complications, and he's to the patient, and he's doing something which is causing complications to a surrogate. So Dr. Shailesh, 2 minutes of rejoinder to all his points.
Yeah, thank you very much. I think I was, Dr. Krishna Kumar's talk was like talking and listening to my grandfather. He lives in 1920 era. And he is talking like he is quoting mythology because he doesn't have enough statistics to prove what is the correct thing. He all goes in his heart of his heart.
Run away from the field.
Yes, he is completely out of the field because he was so afraid to talk about uterine transplant that even his computer gave away. It said there's no point pointing with the technology. Look at my technology, it's going high speed. Look at his technology, completely mythological, no bearing. He knows in his heart that surrogacy is commercial. He knows in his heart the price, and he's talking out of his hat when he says that there are complications. Not a single person out of uterine transplant has died in the world. Forget about India. Secondly, it is something because he's a male, he is not able to understand what a woman feels. Think about a woman who is born without the uterus. When I did my first transplant, I begged to every IVF center to send a person so that I could do a transplant. Everybody thought crazy, like Dr. Krishna Kumar, because IVF specialists always reject something which is going to put blame on their practice. So the moment I did the transplant, 626 patients waiting for us, all MRK. So these are the troubles which were underneath. The moment the technology came, more people are coming forward. As a man, it is like, this Arnold Schwarzenegger's, that one, at least एक बार आदमी ने pregnant होना चाहिए, then he will understand what is it pregnant. That is what our wives always say, एक बार तुम pregnant होके देखो फिर क्या तकलीफ होता है. So think about the woman who cannot become pregnant. This is a very easy way out.
Krishna Kumar, he has rejoined it by saying that you are talking like a grandfather from Mahabharata. And you have to be on the 21st century and not live in Mahabharata time.
Yes, I do. I will not deny that, but you have to stay for the present. You have to stay for the present, and you have to realize what is the present required. So let me finish. Suddenly electricity went off, so I couldn't conclude the last two slides. So in the rejoinder, I'm getting a chance. Can I start?
अरे डर गया कंप्यूटर तुम्हारा.
अरे तुमने वहां से ही ये कर दिया.
Retired. He told the bouncer which hit him, so he had to take some medical.
So it's no match. Can I start? My rejoinder, I'll finish.
Yes, yes.
Yeah, it is no match as far as safety is concerned. What is more important, the experience of pregnancy and gestational, as my friend says, or the health and woman of the future child.
He's gone.
And definitely in this endoscopic Premier League, surrogacy is the established Premier League right now. Uterus transplant is an experimental primary league. And with the ART and surrogacy law in place, the local authority empire, the DRS is there to achieve IVF's holy grail. Why should IVF play an experimental primary league? I would rather play the established Premier League of IVF, and it's a long way to go before we can debate on this topic. At the moment, there is no ground now to think of uterus transplant. It is only surrogacy for IVF ET. Thank you.
Thank you very much for bringing those points up in your rejoinder. Dr. Pavandhir, your comments.
Sir, I would like to... Hello, I am audible?
Yeah, very audible. But neutral comments, please, huh? Don't try to...
I would like to say that surrogacy is the standard method for having a baby. The only thing is our law people, our medical persons, our IAG president, ISAR presidents have to have a meeting with the government of India to make integrated committee formulation for surrogacy, so that the women who are economically poor may not.
So that was comments on surrogacy. We have to do it legally. Well, Niranjan, can you read out some comments? All the audience, please vote right now. We are going to add the polls in next 2 minutes. So those who have not voted, question number 1, would you prefer safe, efficient surgery as robotic or conventional? And second, would you advise your uterine cause factor infertility, a uterine transplant or a surrogacy? What will you offer? So those are the 2 questions for voting. Dr. Niranjan Chauhan.
Welcome. Wonderful power plate number 2 by the one and only numero uno, Dr. Shailesh Puntambekar. He is a he-man for the uterine transplant, number 1 in India, the Southeast Asian guy. And we had Dr. Krishna Kumar along with us, and the way which he presented, I think there was some power disruption in between, and probably it is related to the Galaxy Pune Center trying to come in the way of the JK Hospital Women's, and there was some undercurrents and underfires which we could see. And obviously we are waiting for the poll results. But I want to tell you, there are many comments which have come. Dr. Pratibha Singh, Bhagalpur, rightly said, Dr. Shailesh, uterine transplant will give wholesome experience to those who have no hopes. Congratulations, sir, for bringing that smile to such couples. Oh, Dr. Puntambekar, you have a lot of fans. I can see that. Many comments coming on your way. Dr. Jyoti Malik from Bahadurgarh, uterine transplants gives much more satisfaction to the woman, gives her self-esteem back, though she has to undergo 3 surgeries and lot of drugs to prevent the rejection. Dr. Sambit Nanda from Mumbai, Anshumala Shukla, this is for you, and Chaitali Mahajan. Robotics helps doctors in Western countries by reducing the surgical complications because of its ease, which is overcome by Indians with superior surgical skills. So, well, we have many comments which are coming, and congratulations to both of you. Now I would request the host to please go ahead and announce the results. Support, kindly put it in front of Dr. Narendra Malhotra, our umpires, and Dr. Pavandhir. Let them announce the results. We are waiting. The strategic timeout is over.
We have over 1,500 audience who have polled on this. The percentage is being calculated just now. because the votes are still coming. So I think
Yes.
we can cut off the votes now and get a percentage, Mr. Subbu and Meenal. In the meantime, let me get you what I could make out of these two debates. And any one of the other debaters wants to give a comment. Dr. Shailesh, you would like to comment on robotic versus conventional. Dr. Chaitali on surrogacy versus uterine transplant. Dr. Anshumala, uterine transplant or surrogacy. We can have a voting amongst yourself on the other debates. Shailesh, what about robotic versus conventional?
I think robotic technology is here to stay, and it is basically making an average surgeon do a little better surgery. So it fills up the gap. But at the same time, I mean, you and I would be happy. We have the new robot with us, CMR robot. The problem is the cost. And this cost is getting, so if everybody gets to use like the BMW car, if it is available at a lower cost, then I think the model is easy. The biggest objection to this robotic technology is the cost. Once the cost comes down, it's one of the technologies which can be easily mastered. So I think we are only looking at the cost. Scientifically, there is no difference between the robotic and laparoscopic surgery, but it helps you to...
When I see that picture of the robot, 10 things going in my tummy, and some artificial intelligence, no doctor there, the doctor is sitting somewhere else, and it's in artificial intelligence. If it moves the other side, the cursor, instead of my right kidney, the left will go off.
That can happen.
So and then the anesthetist, which we are so used to, and the anesthetist is so used to pulling legs of the surgeon, he's talking to a robot. He's talking to those 10 metallic arms. Abhe chai piyega ki nahi piyega? So that's the lighter side of robotic surgery. Okay, and then of course she said men will operate with a robot. And right now there are only 11 robots in India, as I gather.
No. 11 in Mumbai and Delhi. 11 in Mumbai and Delhi. There are more than 100 robots across India.
More than 100 in. And Chaitali says it's like taking a patient to ICU to measure a blood pressure. To do robotic surgery is like taking a patient to ICU just to measure the blood pressure. And both of them agree for cancer surgery, complicated surgery. If I have to get my prostate removed for prostatic cancer, I will go to a robotic surgeon. Yes.
Correct.
So it is both ways. And let's see, we have the results on. Anyone else can, Krishna Kumar, you want to talk about robots?
No, as you said, rightly, it has its own place and we should use it for those particular conditions like you mentioned, the prostate, and where you have to enter the deep pelvis for the pelvic floor, yes. But not for routine hysterectomy, routine myomectomy, I wouldn't propagate that.
I agree.
And Krishna Kumar took us to gully cricket. Gully cricket, everyone can play. So surrogacy, everyone can do. And it's a uterine transplant. He wants to take us to Abu Dhabi to play on that good pitch. And of course, he took us back to Mahabharat. So let's read the poll for the first poll.
Dr. Narendra Malhotra, there is polls are being still getting calculated. We are still waiting for the final results. We have got more than 1,500 voters who have been waiting. The computation is going on. The wonderful power play 1 and 2 has been excellently been displayed on our stadium. The members are watching. The results are going to be out. Dr. Narendra Malhotra and Dr. Pavandir, kindly be ready on your screen to be getting the final votes being calculated very soon.
Comments which have come?
Yes. Dr. Jyoti Malik Bahadurgar, well fought match by the two giants, uterine transplant and surrogacy. Anurita Singh Meerut, patients if presented with both options, they will prefer transplant. Dr. Bharti Saran Bareli enjoyed the cricket modified, and we have got many messages which are coming. It's amazing. Oh my God, I think the results are out. Dr. Narendra Malhotra, Dr. Pavandir, you are going to announce the results now, and the audience is waiting.
Waiting.
First debate on robots versus conventional surgery. We did expect that conventional surgery would score a bit more, but looking at the results, 30% are in favor of robotic surgery, which is a huge number. And I think that is 30% of people, general gynecologists, are going to prefer robotic surgery today. So India, the future is here. The future is here. It's not putting in the scope. It's 70-30, and I expected it 90-10, but it's 70-30. It's a fantastic thing. It's almost as equal to both of you. Well debated.
Thank you.
The second debate, of course, is gone to a super over. It's a tie. It's 50-50. Imagine it's a tie. So 50% want uterine transplant, 50% want IVF surrogacy. Fantastic. So this is a real tie, a real great debate between the two giants. So that is it. Thank you, Dr. Niranjan, for giving Pawandeer and me to umpire this lovely match with experts and with super experts. All yours to conclude.
Sir, I would like to remember two great robotic surgeons, Poonam Raj Satpute and Dr. G.K. Tripathi, to whom we lost so early at a younger age.
Thank you, Dr. Narendra Malhotra, Dr. Pawandeer, to be there as umpires for this Endoscopy Premier League, which has been watched by more than 1,500 members. And I would like to thank each of the panelists from the bottom of my heart. Power Play 1, Dr. Anshumala Shukla, Dr. Chaitali Mahajan Trivedi, to do a wonderful presentation on these wonderful topics of robotic versus conventional. And we had the gods of endoscopy and god of IVF, uterine transplant, and we have Dr. Krishna Kumar. On a serious note, I would like to thank each one of you to look at this retrospectively, that such a concept is being conducted, and I get lot of comments, lot of giggles, lot of happiness, lot of the beautiful I hear the voices when I talk to my members, and they are so happy in this corona pandemic time that we are making them so wonderfully being negotiating with this type of a play. Thanks a lot to all the doctors. You have embellished this platform with your time, crisp presentation and rebuttals. Thanks a ton. And till then, we come back with you with the EPL episode number 4. Shabakher, Shubhratri, good night, take care,
Bye-bye.
be strong, be safe.
Yes. Bye.
Thank you.
Thank you.
Thank you, Niranjan. Bye.